Okay, let's talk about GI pathology. GI pathology. In this GI pathology, we are going to be starting from oral pathologies. First of all, we are going to be talking about aphthous ulcer. What is this called? It's called cancer sore. Yeah, common oral lesion that appears as a painful, shallow, round to oval ulcer. It is covered by yellowish exudate. Looking at the picture A, you're looking at a picture A. This is the picture A. You have an exudate. Okay. Recurrent. But if you were to have aphthous ulcer recurrently, recurrent aphthous stomatitis is associated with celiac disease, IBD, SLE, Behçet syndrome. So what is Behçet syndrome? Recurrent aphthous ulcers, recurrent genitalial ulcers, and one extra thing, and that's called Behçet syndrome, and also HIV infections. So in a recurrent, just think about this way: in recurrent aphthous ulcer, just think about autoimmune diseases, autoimmune problem, most likely, or immunodeficiency, like in HIV. What are the autoimmune? You have the celiac, IBD, SLE, all autoimmune, and HIV, immunodeficiency. So that's the recurrent aphthous ulcer. Squamous cell carcinoma of the oral mucosa. It is the most common malignancy of the oral cavity. Usually affects the tongue, right? Associated with tobacco for sure, alcohol for sure, direct irritation. HPV 16, most important, presents as a non-healing ulcers. Presents as a non-healing ulcer with the irregular margin is raised borders. So you have the irregular margin of that ulcer, and also heaped up raised margins. While comparing that to some other ulcers, they're not gonna have the irregular borders. Instead, they will have normal borders and not heaped up margins. Normal margins, not heaped up. But if you see irregular and a heaped up margins, just think about some sort of malignancy. Okay, leukoplakia, which is a white patch, leuko-white patch, erythroplakia, red patch. They are the precursor lesions. Looking at picture white patch as a B, you have the leukoplakia, white patch. Awesome. Coming to the sialolithiasis. Sialolithiasis is the stone formation in the ducts of the major salivary glands. For example, which is the major? Parotid is the major salivary gland. Then you have the submandibular. Then you have the sublingual. It is associated with salivary stasis, like dehydration and trauma. So you have dried the salivary secretions in the salivary gland duct. The duct has dried so much that it formed a stone. So salivary stasis within that duct. Why do we have salivary stasis? Because of dehydration. So drink plenty of water, guys. On trauma, do not get punched in the face. That's the other way to go. But it's going to cause recurrent pre and periperennial pain. So either after you get punched, don't eat food, man. I mean, why? Because as soon as you think of food or start eating the food, you will have the pain and swelling in the affected gland. Sialadenitis, that is the adenitis, again, inflammation of the salivary glands due to obstruction, infection, either due to obstruction, same way. Sialolithiasis can lead to sialadenitis infection. I mean, Dr. Sattar has given a basic general rule, which is really good. Anytime you block a tube, behind that tube you will have infection. So here you go, sialolithiasis, because of obstruction of that duct of the salivary gland. Infection due to Staph aureus is the most common, or the mumps. Staph aureus is going to give you unilateral sialadenitis, meaning you will have unilateral gland inflammation, you will have unilateral salivary gland inflammation, or in the mumps you will have bilateral gland inflammation, or most importantly, you will have bilateral parotid gland inflammation. Or the second thing is the immune-mediated mechanism like Sjogren's syndrome. Then you have these salivary gland tumors, usually benign, most likely affected the parotid gland because that's the major gland. Submandibular sublinguals, they are the minor salivary glands. But if you have a tumor on these minor glands, it's gotta be malignant. Again, if you're hitting the parotid, which is a big gland, the major gland, I mean, that gland is already big, so it's only benign tumor, most commonly. But if you're hitting the small glands, I mean, you're a big guy, a malignant thing, hitting a small gland, that's got to be malignancy or a malignant tumor, right? Typically presents with, if you have any tumor, it's going to present with painless. Why would you have a pain in tumor, right? Painless mass, for sure mass. And swelling, that mass is going to give you swelling. Facial paralysis or pain suggest malignant involvement. So again, journal rule was benign parotid, but if that parotid gland, that tumor in the parotid gland causes facial paralysis, let's say it is impinging on that facial nerve, that means it has grown so much, so that's got to be malignant. It suggests malignant involvement. Okay, coming to pleomorphic adenoma. Pleomorphic adenoma. It's a mixed tumor. It is the most common salivary gland tumor composed of, what do you mean by mixed? It is composed of not only one thing, but two things together, like choroid myxoid stroma, chondromyxoid stroma, and epithelium, and recurs if incompletely excised or ruptured intraoperatively. So this pleomorphic adenoma, I mean, you just think about this as a mixed tumor. What is the mixed meaning? You have epithelium and also the chondromyxoid stroma. And you have to cut all its margins. It has an irregular margins, so only the expert in this thing can cut it. Otherwise, if you're an incompetent surgeon, you're not going to cut it right, so it's going to recur. But if you cut it in a perfect way, it's not going to recur. The second, and this is the most common, pleomorphic adenoma is most common salivary gland tumor. Second thing is the Warthin tumor. War. Who's going on war? Warriors from Germany love smoking. Okay, that's the mnemonic. But Warthin tumor, it's the other name is the papillary cyst adenoma lymphomatosum. What a long name for such a small thing. But it's a benign cystic tumor with germinal centers. Okay, maybe bilateral or multifocal, typically found in people who smoke. So smoking irritates. Smoking irritation leads to formation of germinal centers, and those germinal centers forming tumor. So warriors from Germany, warriors means Warthin tumor, Germany means germinal centers, smoking means smoking. Smoking causes germinal centers to grow into a tumor called Warthin. Awesome. Now lastly, what do we have? We have the muco, one thing, epidermoid, two things, carcinoma, most common malignant tumor. You have a mucinous, muco, epidermoid, epithelial like squamous components in that tumor. Okay, looking at the picture here, this is sialolithiasis. I mean, don't look at the teeth, man. Sialolithiasis. Not this, that, okay. And also, you have this pleomorphic adenoma, this guy, salivary gland tumor. Okay, moving on to the easiest pathology, not easiest, but a really good pathology. What do you have? You have the achalasia, without achalasia relaxation. So you have the failure of LES to relax. So you have when you have a failure of LES to relax, so what's happening? You have increase in LES. Because LES is not relaxing, right? So when LES is not relaxing, you're increasing the increasing the LES. Why do you have a failure of LES? due to degeneration of those inhibitory neurons. What do they contain? NO, nitric oxide, and VIP. In the myenteric plexus of the esophageal wall. Remember the mnemonic MS. Inner longitudinal, outer. What was that? I totally forgot. But outer longitudinal, inner circular. Yeah, outer longitudinal, inner circular. I believe I'm right, but if not, just look in your book. You have the myenteric, M for myenteric, myenteric, M for motility, M. So when you don't have this, you're not having any motility, right? So that's why you have the failure of LES to relax. You have no motility. Okay, but again, the problem is nitric oxide and VIP is not there. Okay. It is if you have a primary achalasia, is idiopathic. Secondary could be due to Chagas disease, which is a T-cruise infection, or the extra esophageal malignancies, which causes mass effect or paraneoplastic. Chagas disease can cause achalasia, CHA. What a way to remember. I mean, that achalasia is going to present with progressive dysphagia to solids and liquids. Okay, versus obstruction primarily solid. So obstruction meaning like carcinoma. That is going to give you primarily solids first. But here you have the solids and liquid at the same time. It is associated with increase in esophageal cancer. Why? Because you have all this food that is causing irritation. That irritation is eventually going to cause cancer. Manometry finding includes uncoordinated or absent peristalsis. So either you have so much peristalsis, because the problem is here, right? It's not that it goes. Esophagus is like doing its peristalsis. Or you have the esophagus like, man, I'm tired now, can't do any more peristalsis. So you will have an absent peristalsis with increase, but this is the important increase in LES resting pressure. That's the manometry finding. A barium swallow is diagnostic. It's going to show you dilated esophagus with area of distal stenosis. Dilated esophagus with distal stenosis, but beak appearance. Treatment is either surgery, give endoscopic procedures like botulinum toxin injection. Okay. Yeah, pretty much. Either you do the surgery or give the botulinum toxin injection. Okay. So what is that botulinum toxin going to do? Well, that botulinum toxin is going to block the it's going to inhibit the acetylcholine in the LES, right? Secretion of acetylcholine in the LES, which causes LES to relax. And when you relax the LES, all the food is going, and you are good. You're saying life is good. The other things that you can give, as far as the drugs are concerned, you can give CCBs, calcium channel blockers. You can give atropine. Okay. That's all we have. One more thing, we have the chest x-ray can show you dilated esophagus as seen here. Dilated or widening of esophagus. And most importantly, if you were to do endoscopy, that's going to give you normal mucosa. So endoscopy, you will have normal mucosa because the mucosa is all normal. All you have is an increase in LES pressure. All right, moving on to other esophageal pathologies. There are plenty of them, but just know the differentials, like how to differentiate from one to other. But let's talk about it. GERD. gastroesophageal reflux disease. There is a transient decrease in ileus tone. So when you decrease the ileus tone, all of that acid is going up, causing GERD, right? But it's only a transient time. You don't have GERD all the time, right? Yeah. So you just have it for some time. And that sometime is painful. You want to take a milk after that. That if it helps. I don't know. Should do a research on that, but let's figure out right now. Here. Commonly presented as heartburn, regurg, dysphagia. Yeah. May also present as chronic cough. Very important. Chronic cough. Chronic cough. Hoarseness. Laryngopharyngeal reflux associated with asthma. Complications include erosive. So if you have GERD, you can cause erosive esophagitis. That acid is going to erode your esophagus, causing erosive esophagitis. That erosions can cause strictures like joining, and Barrett esophagus, change in the epithelium to counter the stress placed on that. Okay, so here, yeah, that's all we have for the GERD. Is there anything that I could tell? Yeah, pregnancy also, as they said, that associated with asthma, but also pregnancy. Why? Because the uterus, is impinging on the stomach, and can cause the GERD in a pregnant woman. Okay, let's talk about the next thing now. Esophagitis. That esophagitis, again, itis, inflammation of the esophageal mucosa, present with odonophagia and or dysphagia. Odonophagia, painful swallowing. Dysphagia, difficulty in swallowing. Types are reflex erosive esophagitis. Okay, look, esophagitis, right? So reflex erosive, as we talked about GERD, causing erosive esophagitis, secondary to GERD. Second thing is medication-induced esophagitis. Which medications cause that? Well, the bisphosphonate, like aldronate, tetracyclines, NSAIDs, potassium, and also the iron, the ferrous sulfate. Okay, esophagitis by eosinophilic esophagitis. Why eosinophils? Because it's an atopic disorder. It is a chronic immune-mediated eosinophils predominant, associated with atopic diseases like asthma, esophageal rings and linear furrows on the endoscopy. So whenever you see rings and linear furrows, I'm going to show you like this, rings and linear furrows on the endoscopy. But also they have mentioned that you have some eosinophils. They did a biopsy that showed some eosinophils. Or they just tell you, hey, there's an atopic disorder. The guy has asthma. That's the eosinophilic esophagitis. But esophageal rings and linear furrows on endoscopy. Infectious one, esophagitis, we have the Candida infection. Most common, the white pseudomembranes. I'm going to show you in a minute. The HSV1, punched out ulcers, CMV, linear ulcers associated with immunosuppression. And lastly, we are looking at the corrosive esophagitis secondary caustic ingestion. Okay. Let's look at here the Candida infection and the pseudomembranes. Pseudomembranes in the Candida infections. Okay. These pseudomembranes, these are, if you can see here, they are the gray white patches of pseudomembrane on the erythematous mucosa. If you were to look at them microscopically, you will see pseudohyphae, and the yeast cells budding, poring. They will be budding and spore embedded within the necrotic debris invading the mucosal cells. The treatment to this is fluconazole, because this is in esophagus. Fluconazole. So if you have immunocompromised patient, you are going to be looking at three things. One thing, the most common, is the Candida infection causing esophagitis. The second thing, you can be looking at HSV1. And the third thing, you'll be looking at CMV, all in immunocompromised state. How do we differentiate HSV1 versus CMV? Well, HSV1, it's going to give you small punched out ulcers, and also it's going to give you intranuclear cells. But that's the differentiation. Let me just give me 1 second before I give you that information. I would have to look at it. Give me 1 second. Okay, yeah. So HSV1, first of all, you already know that it's a punched out ulcers. Second thing, is going to give you on your biopsy. If you were to do biopsy for this thing, you will see eosinophilic, intranuclear inclusions, and multinucleated giant cells. So first of all, eosinophils, and also the multinuclear giant cells. In the biopsy, treatment for this thing is acyclovir, while the CMV, cytomegalovirus, you on the biopsy you have intranuclear and cytoplasmic inclusions. So not only intranuclear, this guy only had the intranuclear inclusions, right? So you have intranuclear plus cytoplasmic inclusions. Okay, and that's on the biopsy. The treatment for the CMV is going to be ganciclovir. Okay, so that's pretty much it for these two things, but this is important. Okay, let's talk about Plummer-Vinson syndrome now. Plummer-Vinson is a triad of dysphagia, iron deficiency anemia, esophageal webs. Plummer dies. Plummer-Vinson syndrome, DIE. Dysphagia, iron deficiency anemia, esophageal webs. Iron deficiency anemia is going to give you glossitis or red tongue as well, or burning tongue, difficulty swallowing, which is also already dysphagia. Increase risk of esophageal squamous carcinoma, maybe associated with glossitis. Glossitis. Yeah, you got it. Mallory-Weiss syndrome, you have a longitudinal partial thickness. One thing, partial thickness, longitudinal to Mallory, longitudinal laceration of the gastroesophageal junction, confined to the mucosa and submucosa. So this is your G junction, let's say. it is going to be confined to mucosa, submucosa. So it's not a full transmural thickness ulcer. It's only a partial thickness ulcer. It's only a partial thickness ulcer. That's the Mallory-Weiss. It is going to be confined to mucosa because it is due to severe. Why did it occur? Because of severe vomiting. Often presents with hematemesis, because you have the blood, right? You have that. If you did the mucosa submucosa damage, you got the blood into the esophagus, which is going to go out as hematemesis, right? Plus minus abdominal back pain, because again, you do have pain because of that rupture, partial thickness rupture, but there is a rupture, right? So you have pain, usually found in the patients with alcohol use disorder or bulimia nervosa. Okay, the alcohol use disorder and bulimia nervosa. Okay, and it contrasts this thing with Bohr-Haave. Bohr-Haave syndrome, it's a transmural, usually distal esophageal rupture due to violent drenching. So here the treatment is what? Self-limited. It's gonna heal on its own because it's only mucosa submucosal damage. Here, it's a full-blown rupture of the transmural. The whole esophageal rupture has occurred. That's the Bohr-Haave syndrome. So let's just talk about esophageal perforation. So let's read this. Is most commonly iatrogenic following esophageal instrumentation. Iatrogenic due to instrumentation. Non-iatrogenic include spontaneous rupture, foreign body ingestion, trauma, malignancy may present with. So if you have a rupture here, for sure that air is going to go out as well. The blood is going to be going off the charts, but again, we also have air that's going to go out to this full thickness rupture. That is the mediastinum, arrows in C. Looking at C here, this black thing. Look, everything else is normal, and look at this black. Let me erase this so you can see. This black thing. This is due to esophageal rupture that caused the air to go into the thorax, causing pneumomediastinum, and looking at black air in the picture. Subcutaneous emphysema may be due to dissecting air. Signs include crepitus, so very important. Crepitus in the neck region of the chest wall. So as soon as you push on the chest wall or in the neck, you feel the crepitus because of that air blebs or air into that underlying areas. Okay, and one of them is the Bohr-Haave syndrome, where you're talking about it, that it is due to violent drenching. This guy's due to violent drenching. The other ones could be due to iatrogenic, non-iatrogenic, meaning foreign body, trauma, or malignancy. Okay, so let's talk about now the varices. Esophageal varices, right here. Esophageal varices are the dilated submucosal vein, arrows in B. Look at this, wow. Look at this, wow. These are the varices. These are the dilated submucosal veins in the lower 1/3 of the esophagus, secondary to portal hypertension. Common in patients with cirrhosis leading to backflow leading to varices, causing esophageal varices. Portal hypertension, same thing. Maybe the source of life-threatening hematemesis. If they were to rupture, as the blood is not even going forward, so everything is backed up. If they were to rupture, a lot of blood is going to go out. A lot. So it's a life-threatening. Where did I mention? Life-threatening hematemesis. Okay. All right, now you have the distal esophageal spasm. You have the formerly called the diffuse esophageal spasm. Now it's called easy naming. Distal esophageal spasm. Okay. Spontaneous non-spasm. That's why it's non-peristaltic. Uncoordinated contraction of the esophagus with normal LES pressure. Presents with dysphagia, angina-like pain because it's contracting in an uncoordinated fashion. So it's contracting like this. It's corkscrew appearance. It's going to show you a corkscrew appearance, just like this. So it's contracting so much. With uncoordinated, that means, let's talk about what is coordinated, what is uncoordinated. Coordinated means that, so you have a contraction of the upper part, the food goes down, there's a contraction of the lower part, the food goes there. But uncoordinated means this guy is also contracting, this guy is also contracting, in an uncoordinated manner. So you have angina-like pain, chest pain, barium swallow is going to reveal a corkscrew esophagus right here. Manometry is diagnostic, which is going to show you an uncoordinated peristalsis. Treatment includes nitrates and CCBs. Stop this contraction, give CCBs and nitrates. Okay. Now, scleroderma esophageal involvement, esophageal smooth muscle atrophy. In scleroderma, you have the atrophy esophageal smooth muscles, leading to decrease in LES pressure, and distal esophageal dysmotility leads to acid reflux and dysphagia. Okay, leading to strictures, Barrett esophagus. Again, I mean, this is simple. You have the smooth muscle atrophy. When you have the smooth muscle atrophy, you decrease the LES pressure, right? And because of the smooth muscle atrophy, one thing is there and one thing is you have distal esophageal dysmotility. Now, when you decrease the LES, guess what? All of it, the acid is going to go back up. When it's going to go reflux, it's going to cause dysphagia. The acid is going to cause strictures. It can lead into changing the cell types and causing Barrett esophagus, or it can go all the way up and cause aspiration. It is for sure the part of CREST syndrome in scleroderma. Now, we already talked about the esophageal perforation already. Okay, yeah, let's hit the esophagus for today. Okay, so Barrett esophagus. What is Barrett esophagus? Barrett esophagus is specialized in intestinal metaplasia. Specialized intestinal metaplasia. Arrows in B, arrows in A. Okay, look at this redness. So it could be like beefy red tongues. But this is, they ask you, hey, what is this? It is not carcinoma. Carcinoma, you would see some mass protrusions, right? So here, like beefy red tongues, that is the Barrett esophagus. It is the replacement of non-keratinizing, very important, non-keratinizing stratified squamous epithelium with intestinal epithelium, which is a non-ciliated columnar with the goblet cells. So non-keratinizing stratified squamous has been converted to non-ciliated columnar cells with the goblet cells. Arrows in B. Look at these goblet cells. Okay, and these are the columnar, non-ciliated columnar cells with the goblet cells. Okay, in the distal esophagus, due to chronic GERD. So chronic GERD gave you causes the metaplasia. So chronic GERD cause this metaplasia to occur so that they can bear the stress that has been put on them. Okay. Associated with increased risk of esophageal adenocarcinoma. Okay, metaplasia leading to carcinoma. Okay. Look at the picture: esophagus, lower esophageal sphincter, squamous columnar junction, or the Z line. And look at these beefy red tongues here, and the redness in the Barrett esophagus. Okay, Now let's talk about esophageal cancer. It typically presents with progressive dysphagia. First to solids, then to liquids. First solids, then liquids, and a weight loss. Esophageal cancer. Aggressive course due to lack of serosa in the esophageal wall. So it's nothing is there to stop the cancer to go distant. So that's why it's aggressive course, and it's going to cause obstruction of all the other nearby structures. Allowing rapid extension. Poor prognosis due to advanced disease at presentation. So you present when it has been advanced. Okay, so you have the squamous cell carcinoma. Squamous cell carcinoma. Why are we saying squamous cell adenocarcinoma are the two different things? Because that's the normal mucosa. Normal mucosa of the upper 2/3 is the squamous cells. Lower 2/3, it is the lower 1/3. My bad, is the adenocarcinoma because it has the glands. Okay, so let's talk about how things are occurring here. Okay, so squamous cell carcinoma upper 2/3 risk factors are, again, the biggest risk factor is irritation, because as soon as you take something in the mouth, what is the first thing is going to hit after in the esophagus? The first thing is going to hit the upper 2/3, the squamous cells. So irritation. Alcohol leads to irritation, hot liquids, the caustic strictures, the smoking, achalasia leading to a lot of food leads to irritation, and also nitrosamines rich foods. Okay, that's what we have. And prevalence more common worldwide. Worldwide is common, but adenocarcinoma A for America, so it's more common in America. How? Let's figure that out. Lower 1/3, chronic GERD. Obesity, very common in America. Chronic obesity causing chronic GERD, very common. Barrett esophagus, that GERD causing Barrett esophagus, very common. Okay, but they haven't mentioned obesity. Wow. Obesity, very common. Tobacco smoking. Have they mentioned tobacco smoking up top? Well, they have mentioned smoking, not just tobacco. So it's a confused state. But anyways, let's think about tobacco smoking. Okay. Yes. So what else? Yeah, that's more common in America. What else? If you were to have, now let's talk about metastasis. If you were to have the metastasis of this upper 2/3, where are they going to go if you have a so you will have the metastasis for the squamous cell. They are going to go into the mediastinal, because it is sort of a mediastinum, right? Mediastinal lymph nodes, while the lower 1/3 is gonna go into abdominal lymph nodes. Okay, so that's how the metastasis occurs. Now, more commonly, what we really need to know about this thing is the how. If you were to do biopsy, you have that. If you were to do biopsy, what do you see for squamous cell carcinoma? So because it's a squamous cell, so you will see keratin pearls, keratin nest or pearls, and intracellular bridging, and eosinophilic cytoplasm, basically saying pink cytoplasm with intracellular bridging, and the keratin pearls or nest of keratin. That's the squamous cell. Adenocarcinoma, you will see invasive patches of dysplastic mucin. First of all, dysplastic because it's a carcinoma. The second thing is the mucin producing cells, which is adenocarcinoma, which is a secretes gland, right? Mucin producing cells that form glands. So dysplastic mucin producing cells that form glands. Okay. So that's the way to go. And for the treatment purposes, you can just think about surgical removal for chemo, radiotherapy, and also this stent placement to keep the esophagus open. Okay, so that's all for today.